Hello, this is Micky Tripathi. I'm the National Coordinator for Health Information Technology, and I'm delighted to be here today. I know this is a diverse audience in terms of private and public, as well as from a wide variety of countries. So what I'd like to do is give a broad overview of the U.S. federal government's health IT strategy and goals, with a particular focus on a couple of things that I think hopefully all of you are interested in, which is the programs that we have that are focused specifically on things that have to do with the innovation economy. So what are our high-level goals in the U.S. with respect to what we'd like to accomplish in the health IT infrastructure from a federal government perspective? Well, we certainly want a health IT system that directly serves patients, providers, payers, public health, and developers. Developers are very important in that list. We don't get innovation if it's not open to innovators, and so we take very seriously wanting to be able to make sure that what we're doing is going to support the entire spectrum or the entire value chain of healthcare delivery and public health, and that includes technology developers and all of those who are developing solutions for providers and public health practitioners to be able to use to do their day-to-day jobs. We also recognize that is not something that can be directed from the top down. We can't regulate or require innovation. It's really about creating a business technical environment that promotes and sustains organic innovation from the bottom up. So as I'll describe in a little while, that's a lot of our focus is figuring out how we strike that right balance of being able to provide some directional goals to the industry and setting up some guardrails, but doing that in a way that helps cultivate the sort of the organic innovation that comes only from the innovators working day to day in the trenches to solve real problems. We also want a platform-based business and technical model, and that's sort of key to this idea of how do we think about innovation, how do we think about platforms for innovation, as we think about the way that platform technology models and platform business models have just created a huge amount of value in almost every other part of the internet economy. We want to be able to bring that to healthcare, and we have a variety of ways that we're trying to do that. And the reason we believe in that is that it really allows for a rich and thriving app ecosystem and complements the EHR systems that are in place today, but allows that, so that very specific and rich type of functionality on top of that can substitute, that can plug in to different systems, plug in across the healthcare value chain in ways that that the existing medical record systems may not be able to do natively. So we very much believe that that's an important part of how we want to develop the health IT ecosystem in the U.S. going forward. We also want health information networks that operate in the background to make basic clinical data available ubiquitously across the care continuum in a commoditized, i.e. low cost, high consistency, high availability way. So that's that floor of interoperability that we want to make sure is in place in all the four corners of the United States. To make sure that regardless of where the provider is and what kind of setting they're in, they know that they're going to get that basic floor of interoperability across their system. And then for the things they want to do on top of that, they've got kind of that platform business and technical model to allow them to have APIs, other kinds of functionalities that will allow them to do more unique and specific things with perhaps more rich interoperability patterns. One challenge for us in the US, and that separates us from much of the industrialized world, is that we have a highly fragmented private healthcare system in the US, both on the supply and the demand sides. And what that means is that the federal government has limited authorities in certain ways, but it also often the federal government is the only force with enough authority and presence in all markets to get collective market action done. And so we think very judiciously, and we try to be very creative in thinking about the kinds of levers that we can pull from a federal government perspective that can help to move the industry forward in ways that are difficult for the industry by itself to do because of that fragmentation problem on the supply side and the demand side. So historically, ONC has focused on the supply side. And what we've done is we identify standards for electronic health record systems and for interoperability across those electronic health record systems. And we instantiate that in the market by certifying electronic health record systems. And what that means is that over 90% of hospitals and ambulatory practices in the US are now using EHR systems, and more important, they're using EHR systems that are certified by my office, by the Office of the National Coordinator. And that guarantees a certain degree of functionality across that entire ecosystem. And what does that mean? That means that they are required to implement certain things like the US CDI, which is the US Core Data for Interoperability. It's like a minimum data set that's required to be available in those systems to be able to exchange with other, with other authorized parties to ensure, again, that floor of interoperability is available across the entire ecosystem. They're required to make that that US CDI data, that minimum data set, available in structured XML document form. And starting in 2022, the end of 2022, they're required to make that available in FHIR-based APIs. For those of you who are not familiar with FHIR, it's a RESTful API, very much in keeping with the modern internet conventions that exist in almost every other part of our economy except for healthcare. And so we're pushing very hard to get those kinds of sort of interaction patterns and interoperability patterns in place in the market so that the market can function the way that the rest of the economy does. Our rules also require that provider organizations and technology developers are required to make available a broader set of information, not just that minimum data set, but what we call EHI, electronic health information, which is most of a medical record. They're required to make that available by October 6, 2022. So that all focuses on the supply side, which is to say that that's the regulations that we have in place to assure that electronic health record vendors that are used by providers in the US have this basic capability to be able to make this kind of information available. Of course, that doesn't mean that anyone has to do it, and that's the other part of the equation. That's the demand side, which is to say that how do we have, how do we have a situation, or how do we motivate providers, the users of those systems, to actually use those capabilities to share the information and to do, to use those systems in ways that help improve both the public health as well as the quality of care and healthcare delivery. So we partner with our federal agency partners to be able to motivate some of that. So with CMS, Medicare and Medicaid, for example, we work with them on the incentives that they provide to providers to be able to use those systems. And then what we do is we ensure that those systems have a certain degree of capability to be able to do those things. We also now have a new focus based on the 21st Century Cures Act that was passed in 2016 that obligates providers, developers, and health information networks to share information. And so that's that's a new authority from ONC. As I said, we've typically been on the supply side. Now we're on the demand side, which is to say that we have regulations in place that went into effect on April 5th that require that provider organizations, technology developers, and these health information networks, it requires or obligates them to share information with other authorized parties, including patients, who are perhaps the most important authorized party. And right now, they're supposed to do that. They're required to make available that US CDI, that minimum data set that I described. And then starting in October next year, they're required to make available that electronic health information. And so what's important about all of that for the, for innovators like many of you in the audience today? What's important about that is, as I said, going back to my original comments, what we're trying to do is create an ecosystem. We're trying to create a foundation based on open APIs, based on sort of standardized expectations of the data that one can expect to have available, so that innovators can come and develop novel apps, other solutions that can access those open APIs, that can access that data, and that can scale it across settings to be able to deliver value in ways that that we're not able, that we haven't been able to accomplish in healthcare today. So that's what I mean by saying that we're what we're focused on is trying to create that climate and trying to create that foundation to be able to have innovation grow on top of it. Another key focus area for us is health equity. And health equity is a key priority of the Biden-Harris administration. Every federal agency right now is deeply considering how its activities address explicit and implicit equity-based issues. ONC ourselves are examining how we can ingrain health equity considerations in federal and market health IT activities. And we're starting with the idea of health equity by design as a concept and seeing where that leads us. We're building on models of privacy by design and safety by design and security by design, which are now common in software development in healthcare workflows, and saying we ought to be giving health equity the same consideration as a design consideration, not something that's just a module or an added feature of, of the way we design software or networks. Of course, it starts with the data. And as a health equity expert told us recently, if you're not counted, you don't count. And so we're starting with the data. One of the things that we've done from the beginning is that US CDI, that US Core Data for Interoperability that I described before. In July, we released version 2 of the US CDI, and that includes social determinants of health data and SOGI, sexual orientation, gender identity data, as future requirements for exchange across EHR systems. We already have requirements for the capture of race, ethnicity, language data in those systems. So with the addition of SDOH and SOGI, we now start to round out that first part, which is saying, let's make sure that technology systems have the ability to capture that information and share that information in structured ways. And now we'll work with our partners and with others to figure out how we motivate everyone to actually use those functionalities and capture that data and use it for the higher level purpose of intervening in the system before health inequities turn into healthcare disparities. So what are we doing on that front? We have a number of things that we have underway. One is that we have a pilot that we're going to be announcing soon to start the process and to pilot referral management to address social determinants of health aligned with clinical care. What does that mean? That means from an EHR system, for example, and if I'm a primary care physician, how do I order legal assistance? How do I order housing assistance through my EHR in the same way that I can order an EKG or that I can order a lab? Where the idea being that not only do I want to be able to have the data that an individual perhaps has housing insecurity or lives in a food desert, but I want to, in as automated as way as possible, be able to intervene upstream to be able to provide them the assistance so that that can help mitigate that housing insecurity or that food insecurity. So we have a pilot that we'll be announcing soon that will work with a particular provider organization and will allow us to start to experiment with those kinds of interoperability pathways and see what lessons are learned that we can share and scale across the industry. Another thing we're starting to focus on is artificial intelligence. As we know, there's problem of bias in training data and algorithm development, as well as the further problem with characterizing it. And how do we start thinking about the uses of that data in ways that support the mitigation of health inequities and that don't contribute to it, even more important. We're following very closely some industry developments, some of them led by Mayo Clinic, that are focused on how do we understand what might be biases in algorithms, and equally important, how do we characterize those in ways that will allow someone who is a prospective user of an algorithm to be able to understand what the biases are in the creation of that algorithm, and then they can decide whether that algorithm is appropriate to their particular use. Final thing I would mention in the area of health equity, which is a really important new program that we're launching, is the Public Health Informatics and Technology Program, which is a workforce training program that is going to be, that's an $80 million program where we will be contracting with a number of minority serving institutions across the US to train public health students, and then be able to place them in public health agencies to help to fill that pipeline of local capacity and to be able to offer opportunities for untapped parts of our population who, for a variety of reasons, have been minoritized, marginalized, and aren't represented in that pipeline. And so that constitutes, both an ethical lapse, but it also constitutes an untapped opportunity to be able to have, sort of parts of our economy that haven't been participating as much in the public health infrastructure to be able to directly participate and contribute to it and offer career pathways there as well. We're really excited about that program as well as we think forward about the various things that we can do to help improve the health equity climate in the country. So I hope this provides a good overview for all of you of our federal government activities in health IT. We're really excited by all that you do and in the innovation economy, and we very much welcome your inputs on how we can assess your efforts. So thank you very much.